Hello, my name is Sikstrom, and I will be doing part one of our translation and dialogue and practice tutorial on an intersectional approach to model construction and evaluation in mental health care. My name is Sikstrom, and I'm a project scientist at CAMH. I'm also a medical anthropologist. My co-presenter is Dr. Marta Maslej, who is a CHR postdoctoral fellow, also at KCNI. We also have two undergraduate trainees who are working with us today, Darla Reslan and Yifan Wang. The objectives of this workshop or this tutorial are threefold. First, we want to expand and reflect on our understanding of who and what makes a population so that we can better measure, identify, and interpret health inequities. We want to learn about the value of an intersectional approach to model construction. And finally, we will conduct an intersectional analysis of the data set, and that will be part two of this tutorial. First, before we get started, I just want to emphasize that we are working within a fair AI framework. And this is a question that Marta and I have explored in a previous publication, asking what is a fair machine learning model? And that work identified three pillars for fairness, which were included transparency, impartiality, and inclusion. And so in today's workshop, we're only going to focus on impartiality. And this is essentially looking at how a model or machine learning or AI might unfairly discriminate against specific groups of people. And so the other dimensions of fairness are also important, but something we're not going to consider for today's tutorial. So the key question for today is who and what is a population? And we ask this because how and when can populations be meaningfully compared? So when we do a fairness assessment to try and understand bias or unfair discrimination in a model, we have to decide which groups of people we want to compare to identify whether or not there's some kind of discrimination happening. How do we do that? Do we know this is an appropriate comparison to make? Is it a meaningful comparison? And what is that, the results of that comparison telling us? So one thing that I find, having worked in the space for a while, that ends up happening is you might compare men and women, and then a question comes out of, well, maybe men and women just have different base rates, or you know. And so this is the kind of question we want to look at. And sometimes it can be hard to answer that question. But when we find the bias, we find this kind of disparity in how a model might treat people, we have to try and understand further. We have to ask whether it's appropriate to deploy it, knowing what we know. So just a reflective activity to get us thinking about what are meaningful comparisons. I just want us to think about how every man is in certain respects like all other men, like some other men, and like no other men, right? So just thinking about, maybe take a moment to think about a group that you might belong in. Maybe this is a study group, a sports team, a choir, an old group of friends that you went to high school with. Maybe think about that group, right? And think about something that that whole group of yours might have in common. So let's say we'll take a soccer team. Let's say that whole group has in common a love of soccer. Now let's think about something that some of your group has in common. Well, it would depend on the makeup of that group. But let's say it's some are boys or identify as boys, and some are individuals who identify as a girl. So that's something the group has in common, but something that makes each of you unique, that could be so many different things. It could be everyone's a different height, it could be everyone's a different age, it could be everyone's different ethnicity, everyone grew up in a different neighborhood. You know, there's a range of things and factors that make us each unique. So it's both what makes us the same, but also the factors that make us different that lead to population disparities in health or in health inequity. So this is just something to think about when we're comparing groups. Are these meaningful differences that we're comparing? And how do we know they're meaningful differences? So this is identify biases that are discriminatory and think about solutions for solving. So to help us, just give some background for how I come to think about what is a population, we're going to draw on some of the work of Nancy Krieger, who is an epidemiologist who's asked these questions. And one of the things she talks about is, in statistics, the causal view that populations are statistical entities composed of component parts defined by innate or intrinsic attributes. So what could be an innate or intrinsic attribute of humans? There's a range of things. Your height, maybe not. Right. And so this idea that humans have innate characteristics that can be compared to one another actually led to the invention of, quote, the average man. And this was developed by Adolf Kettledge. Lots of information out there about him. And what this idea tried to do was establish a population mean, for example. So like the population mean of the average human height, or the average body weight, which is how we have BMI. And this idea, he was originally a physicist, and this idea was actually used to identify the true location of a star or planet, right? Using multiple observatories to arrive at this information. And so for a star, a population mean refers to a location of a physical object. But for a human population, let's say, this actually depends on the population definition. So how we define our group, so we're visiting how do you, what did your group have in common and what did your group have different? Those are how you defined what is a group. But of course, I think there are problems with this, right? So a star isn't actually a real object, whereas for a population, the location of its population mean depends on how the population is defined. So just a simple example of looking at height from the BBC article, we can see that there's lots of ways that a population is defined. Population can be defined as human. So, we could have looked at the mean height of humans over time. Could be by nationality, as this graphic has done. Could be by gender and nationality, which this graphic has also done. But also this graphic defined a population at a single moment in time, in 1914. 2014 to look at change. So, of course, what makes it meaningful to compare 1914 to 2014? And the point is that social relations, not just individual or intrinsic traits, shape population distributions of health. We now sometimes think of this, or can think of this, as the social determinants of health. But there are lots of ways we can think about heterogeneity among humans, both across space and time, and within and between groups. Someone who's written very nicely about this in relation to machine learning and disability studies and design. You know, here's Kedillet's average man, but looked at from above. And one nice thing that Trevineris points out is that the further you get from the mean, which is the center, is that the more heterogeneous the population gets. So you can see that these dots are spaced further and further apart. And what she points out is that as you move further and further out of this average, away from this average man, away from the center of this starburst, things work less for you, but also more diverse people get from one another. So I find this graphic very useful for thinking about difference and heterogeneity in humans and thinking about how we compare people and what makes those comparisons meaningful. So this arrives at the main point of this is like how intersectionality, or the notion of intersectionality, can help us understand these things. And Nancy Krieger's observation that populations are dynamic, constituted by intrinsic relationships both among their members, so between groups, and with other populations that together produce their existence. And this makes causal inference possible. What she is pointing out is that to make conclusions about these differences, we also have to understand how these populations came to be. How do we define them? So race is one example of a group of people that have been historically defined by skin color as being intrinsically related to specific characteristics, right? So these are racial stereotypes, that have been harmful, that promoted all kinds of inequities in society. Same with gender, right? So women couldn't vote, as an example. And so where this notion is helpful is that it helps us understand these relationships between these different groups, which are social constructions. Concepts like gender, class, religion, these are all social constructions that have meaning for us. And it acknowledges that we are all working within these systems and how through various different lenses. And this is a great graphic for trying to visualize that, how varied our human experience can be. So in practice, however, in machine learning in particular, and fair AI in particular, the focus of these comparisons has been on protected groups. And this might, and probably is, for practical reasons, that we have legal obligations to make sure that any medical interventions do not discriminate against groups of people on the left. And so it probably explains why most of the machine learning fairness assessments have taken place on race or sex or gender. But it's important to note that what we might think of as the social determinants of health, the known factors that impact health inequities, such as class or education or your citizenship status, are not protected groups, right? So there isn't how these issues are understood and measured in the literature are quite varied. So it means that we understand some ways that machine learning might unfairly discriminate against people, but there's lots and lots of unfair discrimination happening that we know almost nothing about. So just to highlight the way this has been done in the fair AI field is this great study by Obermeyer and co. that many of you are probably familiar with, which looked at a risk assessment algorithm in insurance. And this was essentially used to identify individuals who required further follow-up for complex care. And this algorithm used total health expenditures as a proxy for disease severity. So what Obermeyer and colleagues found was that actually this algorithm was underestimating disease severity in Black clients. And this is a great paper because it's very thoughtful. It also identifies solutions for this problem. And the reason they say this problem came about, and I would agree with them, is that one of the issues was that they used health expenditures as a proxy for disease severity. And why might that be a problem? Well, one way is that health expenditures might vary because we know that poverty levels in Black populations can be higher. And so even if you are very sick, you might be unwilling to spend money on or unable. There's also a trust factor that they identify, but the fact is they don't actually know why. But one of the things is that they point out is that this is called labeling bias, and it's pernicious because they're measured with inequities built into them. And so how you label a data set, when those labels like Black or white carry structural inequities, then you unknowingly build in these biases. When you assume that this population perhaps is stable or has intrinsic characteristics that aren't related to the social world, you create problems. But they also note, and this is one of the reasons I like this paper, that they also had to assume that all Black and white people were the same. So they made an assumption that Black and white people had some meaningful difference, and this makes sense from what we know about the United States. But they didn't distinguish between Black people or white people based on income or gender. And this likely leads to an underestimation of how poorly this model might be estimating risk for certain groups of people. I would guess, we don't know, but that Black women in particular might be underserved by this. And the reason for that might be called something like misogynoir, but also, if I had a theory, it would be, we know that women who are mothers are much more likely to spend money on their children than men. And so my hypothesis would be that women who are mothers would have low health expenditures, but quite possibly high disease severity. So that's one way that you could think about to cut this pie. What do people have in common? And of course, I think everyone here is likely familiar with the Gender Shades Project, which did a great job at illustrating the value of cutting the pie in a more fine-grained way. Right? In this study, for those who aren't familiar with it, there's a great documentary called Coded Bias, where darker skinned females were less likely to be identified accurately with the facial recognition software. So I want to just conclude with the fact that this notion of intersectionality is not new, that the idea stretches back at least to the Black feminist movement and the suffragette movement, where there was a recognition that women's rights movements were ignoring the realities of Black women in Canada and the United States. There was a wide range of Black activists and scholars, such as Sojourner Truth, who were advocating and saying, look, I am a woman. I might be as stronger than the average man. I eat more as the average man, but am I still a woman? Aren't I also part of this effort to get women's rights in the forefront? So I think what this Sojourner Truth asked a very wise question almost 200 years ago is that what makes a population? And when you define a population a specific way, in this case, ignoring the realities of Black women, you can cause a lot of harm. So to illustrate this in relation to mental health in particular, we have a practice tutorial with Dr. Marta Maslej, who will walk you through a practical applications of these steps and their implications. So thank you very much for this first step, and feel free to reach out if you have any questions. Thanks very much and have a great day.
All right. So in the second practice component of this tutorial, we'll be doing an intersectional bias assessment of a classifier's performance using a hypothetical case scenario based on a long-standing finding from the psychiatric literature. But before we do this, I'm going to give everyone who would like to run the code for this tutorial a chance to open a Colab notebook. So on the screen here, there are 2 links, and these will also be provided to you in the tutorial materials, but you can use them to access an R or Python version of the notebook. So please click on whichever you prefer, and please load the 2 CSV files into Colab. These contain the simulated data sets that we'll be using for the activity. And then please also remember to run the code in the setup section of each notebook. This will just load the packages or modules that we'll need for the analysis. And sometimes this can take a few minutes, so it'll be good to let it run as we introduce you to the case scenario. All right, next slide. So our case scenario for this practice component of the tutorial is based on the finding that Black patients, and men in particular, are diagnosed with schizophrenia at a higher rate than other demographic groups, for example, white men. So schizophrenia is a severe, chronic, and debilitating illness. It's characterized by various symptoms, which are broadly divided into positive and negative symptoms. So positive symptoms include the types of symptoms that generally come to mind when thinking about schizophrenia, like delusions, hallucinations, disorganized speech and thought. But there's also negative symptoms that are common in schizophrenia, and these include a lack of emotion, motivation, or interest in activities. And it's not clear why Black patients are more likely to be diagnosed with this disorder, but it's likely that there are different factors that play a role. So one of them is genetics. And then another is being more likely to reside in stressful environments, which can be a risk factor for developing schizophrenia. But there's also some pretty compelling evidence that this effect is due to diagnostic bias, or the tendency for clinicians to misdiagnose Black patients with schizophrenia when they actually have another illness like an affective disorder or depression. And so there is evidence to suggest that clinicians may be underemphasizing symptoms of depression in Black patients and overemphasizing psychotic symptoms, leading to misdiagnosis and accounting for these higher rates of schizophrenia in Black populations. And there is also some evidence that this tendency may be particularly pronounced for Black men. And why is this important? Well, misdiagnosis can have very negative downstream effects, leading to inequities in care. Schizophrenia is a more serious and stigmatized illness than affective disorder, and it has a poor prognosis. It also involves treatments with greater side effects. And all of these can prolong delays in getting the right treatment, increase patient frustration and distrust, and worsen illness. And so all of these might be disproportionately affecting one subgroup of the population defined by at least 2 intersecting features that we know of, which are gender and race. So next slide, please. So based on this finding, we've developed a hypothetical scenario. So you should note that the scenario and the simulated data that we're using are overly simplified, but we hope this component gives you a sense of how the application of machine learning can exacerbate biases in the training data and how we can evaluate models for bias from an intersectional perspective. So I'd like you to imagine that we have some electronic health record data on 10,000 patients who've been diagnosed at health system A with either affective disorder, which we've denoted in the data with a 0, or schizophrenia, which is denoted with a 1 over the past 10 years. And so this data contains information on the patient's sex and race. We also have some psychosocial information, such as delays in seeking care or their housing status. And then we also have information from clinical assessments related to their symptoms, and there's information on both symptoms of depression as well as schizophrenia. And so hospital executives have had a classifier built that will take this information collected about patients at intake and assign them with a diagnosis of either affective disorder, which is again denoted with a 0, or schizophrenia, which is denoted with a 1. And so these executives have trained a binary classifier on this data to assign new incoming patients a diagnosis so that these patients can be triaged into the appropriate clinic for treatment. Next slide. So now let's say that this hospital is run by some executives who would really like to cut costs. So they really don't want to do any further assessment after this classification. And they're planning to administer treatments to patients following this automated triage. But first, they have to provide some evidence to stakeholders that this classifier works well in diagnosing patients. So they have this test sample of 1,000 patients, which they must use to evaluate their model. And they argue that their classifier works very well based on some impressive sensitivity and specificity values. But the stakeholders aren't fully convinced. So these executives might be a little bit too eager to get this model deployed. So they hire us, so we're an independent consulting firm in this hypothetical scenario, to evaluate the model. So now we're going to move on to the code just to train the model and do a general evaluation.
Okay, so thanks, Marta. So we're just going to move forward with the coding section of this tutorial now. So hopefully the setup has finished running for all of you. We're going to import our libraries, read in our train and test sets, and then this is just a function that will help us plot some graphs to help us visualize the data. So the first thing we want to do is just kind of take a look at what our data looks like. So if we look at the first 5 entries in our train feature set, we'll see kind of what our data looks like. So we have a diagnosis column, and like mentioned, 1 will correspond to schizophrenia, 0 will correspond to affective disorder. We then have our sex and race categories, and this is what we'll be performing our fairness analysis using, as we want to make sure our model is fair with respect to these categories in isolation, as well as the intersectional fairness of both these categories together. We then have a whole bunch of other features that may contribute to a diagnosis, such as housing status, whether there was a delay in seeking care, how much someone had a depressed mood, and so on. And we see that in total, these are all the features that we have in our train set. So if we do a few simple plots here, what we want to do here is just make sure that our train and test sets have a similar distribution of data. So normally you would split the data yourself, but since we've done this in advance for you, we just want to make sure that these 2 sets are similar to each other and that they're kind of drawn from the same population. So we see that indeed in both train and test sets, we have a similar proportion of schizophrenia and affective disorder diagnoses, similar sex distributions, and then race looks similar between the 2 sets as well. And this means we're all good. We can move forward with our model. Something just to note is that we have a lot more Blacks and whites in our data set than Asians and Hispanics. So if this was a real data set, we would be able to hypothesize about why this might be. But obviously, this is just a simulated data set, so we've just set it up this way. Okay, moving forward with the pre-processing, we're just going to drop the diagnoses category from each X set and put that into the Y set such that we can use it for model training. And then we're just going to use one-hot encoding to convert all of our categorical variables into individual variables, such that gender will be encoded as 2 categories, male and female, with 1s and 0s corresponding to whether someone is male or female. And obviously, we'll have the same thing with race. We'll have 4 categories for the 4 different races. And that's just what this code here does. We're going to define the function, apply the transformation, and then just drop the original categories that are now redundant. Okay, now that we have finished pre-processing, we can now train our model. So for this tutorial, we'll be using a simple logistic regression model across 1,000 max iterations. And then we're just going to fit our model and look at our accuracy. So now that our model has been trained, we can see that our accuracy is 98.5 across both our training and test sets. So if we just look at these accuracy metrics, we can say that our model seems to be performing very well. There's very few misclassifications, and by any conventional measure, this model is doing pretty well. And this is probably what the original firm said when they said, look, our model is pretty good, we can implement it. We can look at the confusion matrix as well, which gives us further information about our model, about the sensitivity and specificity. So we see that both of these are high as well, which means our model is correctly picking up on positive cases and correctly rejecting negative cases over 98% of the time. And then we see that our positive and negative predictive values are very, very good as well. So if we look at the confusion matrix we have plotted down here, we have 405 correct negatives, 580 correct true positives, and we're only misclassifying 15 cases out of the 1,000 in my test set. So far, it looks like our model is doing really well, but we haven't yet analyzed it for fairness. And that's where we might see some issues start to creep in. So that's where we're going to move forward in the next portion of this tutorial. Marta will explain what metric we're going to use.
Thanks, Yifan. So we're just going to advance to the next slide. Okay, so for those of you who work with machine learning models, you'll know that there are many performance metrics available. And so we'll need to select one that's most relevant to our specific task. Now, one common application of machine learning in healthcare is the classification of tumors from medical images like chest x-rays as being cancerous or non-cancerous. So in this particular task, which performance metrics are most relevant and why? Next slide. So if you guessed false negative predictions, you'd be right. This is because when classifying tumors as being cancerous or non-cancerous, we would actually prefer to make a mistake and classify a benign tumor as being cancerous as compared to the other way around. And so this is called a false positive or misdiagnosis, and it's better than a false negative or underdiagnosis in this specific circumstance. Why? Well, a false negative would result in a false perception that the patient's okay, which could delay potentially life-saving treatment. And actually, there is a study that suggests when diagnosing the nature of tumors from medical images, false negative rates are higher for disadvantaged or underserved groups defined by intersecting features, for example, low-income Black women. And this study, if you're interested in reading it, is provided here on the bottom of the slide. Oh, next slide. Which performance metric is most important in our case? Next slide. So if you guess that the opposite is true for our case, you would be correct again. A false positive or misdiagnosis is more harmful for a hypothetical scenario because it would lead to unnecessary treatment for schizophrenia being administered, as well as other negative impacts of a schizophrenia diagnosis, like stigma. And while we want every patient to be appropriately diagnosed, clinicians generally agree that it's better to be misdiagnosed with an affective disorder as compared to schizophrenia. And indeed, when diagnosing patients, clinicians tend to rule out any factors that could lead to psychosis or other symptoms of schizophrenia, such as trauma, substance use, and affective disorder, which in some cases can also have psychotic features. So in our example, we'd like to evaluate whether rates of misdiagnosis or false positives are the same across patient groups. And false positive rates are calculated by dividing the false positive predictions by all the negative predictions. So this includes both false positives and true negatives. Next slide. Now, when we're evaluating machine learning models for fairness, we typically examine parity, or the ratio of a given performance metric between two groups of interest. So the numerator in this equation is the metric for the group we're interested in evaluating, and that goes on top. And then the denominator is the same metric for the reference group, which goes on the bottom. And so if the ratio is bigger than 1, the metric is higher in our group of interest. And in our case, we would calculate parity by comparing our group of interest, which is Black men, to our reference group, which is white men, on false positive or misdiagnosis rates. Now, I should mention here that there are some subjective decisions we're making in our fairness assessment. So the first one is that we have chosen white men as our reference group, but we could justify the use of other groups here. Another decision is related to the actual metric itself. So we could have considered some other performance metrics like demographic parity, which refers to the absolute number of positive predictions. Our racial groups are pretty unbalanced. So you may have noticed that Yifan, in his graphs, he noted that we have fewer Asian and Hispanic individuals. So instead of demographic parity, it's possible that proportional parity may be more appropriate since it's similar to demographic parity, except it controls for group size. But because we're primarily interested in misdiagnosis of schizophrenia and not the total number of schizophrenia diagnoses, false positive parity is likely a better fit for our task. So now we'll move on to actually complete the fairness assessment. And so I'll give it over to Yifan, who will continue with the coding.
Okay, so now that we've established what metric we want to use, now it's time to actually implement this. So to do this, we're going to use a library called FairLearn, which can help us compute these metrics as well as the parity rate. And then if you're doing this tutorial in R, you'll be using a package called Fairness. They're analogous to each other and will do similar things. So the way this library works is we first want to specify our sensitive variables. And what sensitive variables are they're features that we want our model not to be biased against. So typically, people will say sensitive variables are things such as race, sex, age, etc. And obviously, these aren't constant. They can vary across different applications. But in our case, we want to make sure our model isn't biased with respect to race. So to do this, we are going to define the metric that we want to use, which, as Marta mentioned, we're going to be using our false positive rate. And that's just going to be computed from our true labels and comparing it to our predictions. And then from that, we can just compute our results to get our false positive rate and false positive rate parity across each of my races. So we'll note that just looking at my false positive rates are all fairly low across the board. So these are expressed in terms of percents. So barely any misclassifications are occurring where individuals are being labeled as schizophrenic, even though they only have affective disorder. However, if we look at the parity in which we're comparing everything relative to the white population, which is our reference group, we'll note that a couple problems start to emerge. So we see that Black and Hispanic individuals have substantially higher false positive rates, which means that they're at a higher risk of being misdiagnosed with schizophrenia, even though they don't have it. And this is not quite fair because our model is being unfair towards these specific subpopulations in a way that it's not towards the white population. So this isn't all we can do, however. So as Laura mentioned in the first part of this tutorial, intersectional bias is incredibly important. And we suspect that this bias may extend to identities defined by the intersect of sex and race. So we're going to do this analysis again for these two subgroups specifically. So this time, our sensitive variable is no longer just race, but it's going to be both race and sex. So we're going to compute these metrics again. And this time, we still note that our false positive rates are pretty good across the board. They are under 1%, and it looks like our model is doing okay just based off these. But once again, if we look at the parity, we see that for Black men specifically, the model has a misdiagnosis rate of 9 times. And this is even higher than above here, where we only had a false positive rate parity of 7 times that of the white population. So we see that by looking at specific subgroups, our model has become even more biased because it is specifically discriminating against Black males. And that's the group which it's most unfair towards. And we actually see that in Black females, we have the opposite trend where we have less false positives compared to white males. So clearly, this model isn't quite fair. It's being discriminatory towards Black males by misdiagnosing them with schizophrenia when they should have affective disorder. So we can look at this problem by plotting each of the diagnoses in the train set stratified across these different subgroups. So across the rows, we have male and female, and each column represents a different race. So we see that each graph looks fairly similar to the others, where they have a similar rate for schizophrenia and affective disorder diagnosis. But we see the one outlier is where we have Black males, and there's a massive rate of diagnosis for schizophrenia compared to affective disorder. Now, this might be due to just environmental factors like Marta mentioned previously, but it also might be due to the clinician bias that we mentioned. And that's what we're really interested in. So in order to fix this problem, one might suspect that retraining the model without the impact of race might solve this problem. So if we remove race, perhaps this classifier will no longer have access to this information and as such be fair with respect to it. And this is an approach that is commonly termed fairness through unawareness, which is the notion that if a model doesn't use a feature during training, it can be said to be fair with respect to that model, with respect to that feature. And we're going to see how this holds up by doing a fairness assessment after we do a retrained model. So the first thing we're going to do is we're going to define and drop our race categories that was encoded by my one-hot encoding. And then we're just going to train a second model, which is identical to the first one, except without our race categories. And if we look at our accuracy scores, we see that they're still pretty high. They're above 98% still. They've dropped slightly because my model has less features to make an accurate predictions. That makes sense, but it's barely a relevant decrease. So the really important thing is whether this model has gotten more fair. And let's take a look at that. If we look at the fairness just within each race, we see that, our false positive rate parity for Black populations has increased to 14 times that of white populations. So not only has removing race not fixed my problem, our false positive rate parity has doubled, and that's very problematic. If we look at our intersectional fairness, we'll see a similar thing where my false positive rate parity for Black males is almost 18, which means that Black males are being misdiagnosed with schizophrenia at an 18 times higher rate than our white males. And clearly, this is still unfair. Removing race from our model didn't fix anything. If anything, it made it more unfair, not only towards the Black race, but also towards the subgroup of Black males. And this is extremely concerning. Marta's going to talk a little bit about why this might be and why removing race didn't do anything.
Thanks, Yifan. So we'll go back to the slides and we'll just move to the next slide. Great. Okay, so why has removing race information from our training data not fixed our problem? We'll recall that there's much evidence in favor of diagnostic bias, or this tendency for clinicians to underemphasize depressive symptoms and overemphasize psychotic symptoms when assessing Black men. But one interesting 2004 study shows that this effect is not necessarily due to the appearance of race. So in this particular study, the researchers examined whether blinding clinicians to a patient's race would remove this diagnostic bias. And so Black and white patients presenting to the hospital with psychosis were evaluated with structured rating scales. And then this evaluation was transcribed. And then cues indicating the patient's race, like their name or other details about their appearance, were removed from the transcription. And the study basically found that regardless of whether clinicians were blinded or unblinded to the patient's race, they still ended up rating the Black men as having increased psychotic symptoms. Next slide. So what's going on here? Well, it's likely that race is associated with other factors that are relevant to misdiagnosis. The diagnostic bias, or tendency to overemphasize symptoms of schizophrenia and underemphasize depressive symptoms, may be related to socio-environmental factors. For example, Black men with depression facing more barriers to receiving health care, which results in a more severe illness when finally assessed. Growing up in low income or stressful environments or early exposures to malnourishment and trauma can also lead to more severe impairment in daily and cognitive functioning, which is also, a feature of schizophrenia. Black patients may also face racialization and poor treatment in health settings, leading them to exhibit paranoia, tension, or distrust at assessment, especially if they're being assessed by a white clinician. And then, of course, the diagnostic instruments that we have are also likely culturally biased, having been deployed on mostly white populations, making it difficult to pick up on symptoms of depression in Black patients or men in particular. So unfortunately, it's just not as simple as removing race from the equation because of these persisting systemic biases, which are related to misdiagnosis. And these biases are reflected in the training data, since the socio-environmental and clinical factors relevant for misdiagnosis are also associated with race. And so it's possible that the model is picking up on these associations despite not having access to the race information related to each patient. And so now that we have evidence for intersectional bias in our model, we could explore some of the training features that might underlie this bias. But before we do this, I would be remiss if I didn't mention a very recent study which takes this point a bit further. So in this study, researchers found that deep learning models trained on medical images like chest x-rays or the images shown here in this slide, these models performed well at predicting the patient's race despite not having access to any racial information. So in this study, the researchers examined some reasonable explanations for how the model was able to do this. For example, they examined for minor anatomical differences between racial groups, like bone density, like whether that was a factor that the model was picking up on. They also examined whether it was due to the cumulative effects of racialization or stress, or even image quality differences between health systems, which could contribute to the model being able to pick up on race, and none of these explanations were supported. So there must be some way that models pick up on race that not even us humans can understand. So now we'll move to the code again, just to take a look at how we might be able to examine which features are contributing to the bias. So I mentioned that other features in the data might be relevant to race in ways that impact diagnosis. So for example, this could reflect emotional and cognitive symptoms, barriers to care, or experiences of racialization. And so the classifier might be picking up on these features in the absence of a race variable. And indeed, when we run some code to examine what the features are that are most important for prediction in our very first model, the model that included race, there is a list of these features shown here on the screen. And so these are just the coefficients that are standardized from 0 to 100. And it basically shows that although race is among the important features, there are also other features related to clinical presentation that are contributing to predicting the outcome. So one way we could probe into the potential factors underlying misdiagnosis of individuals with affective disorder is by examining how features are related to diagnosis in the training set, and then comparing individuals with affective disorder on these features in the test set stratified by intersectional groups. So we'll do that here. So you can see on the screen that Yifan is running the code to generate the graph. And what this graph here is showing is how rumination, which is a cognitive feature of depression, and it just refers to this repetitive, persistent thinking about the depressive episode. So you can see on this graph that rumination is more common in affective disorder than schizophrenia. But if we look at rumination and how individuals with affective disorder are expressing rumination stratified by intersectional groups, which is the next graph on the right there, you can see that Black men, as compared to white men, are less likely to report rumination. And those are the two groups that we're comparing. And then, so that could be a potential factor contributing to misdiagnosis of the model. But of course, the model is picking up on these trends in a variety of features. So we can take a look at one more. So one of the other important features is tension, which is a symptom of schizophrenia. And so again, if we do the same sort of exploration and we take a look at how tension is reported by individuals with affective disorder versus schizophrenia in the training set, you can see that obviously people with schizophrenia are more likely to report tension at their clinical assessment. And then again, if we take a look at how Black men can compare to white men on this particular feature, you can see that Black men are more with affective disorder in the test set are more likely to report tension at the clinical interview. So one thing to note is that actually, we're seeing that a lot of the other groups are also reporting high tension. So it's not the only factor that's contributing potentially to misdiagnosis, but it could be one of the factors that could explain why Black men with affective disorder in the test set are being misdiagnosed with schizophrenia. And so for the sake of time, we won't examine all of the other features that might be contributing to misdiagnosis. So I'll leave that to you to explore if you would like to, but it's just a way to show one potential, or we just wanted to show one potential way that you can probe into the potential factors underlying misdiagnosis. So we'll just return back to the slides now, just to conclude. So we'll go to the next slide. So what do we actually report back to our stakeholders following our intersectional bias assessment? Well, we can conclude that although the model shows excellent performance overall, it may underserve certain demographic groups like Black men and Hispanic women, and it shouldn't be deployed without further assessment by clinicians and further research into the factors contributing to this bias. The hospital should consider some targeted interventions, for example, further assessment for Black men and Hispanic women, especially those reporting or displaying less rumination or more tension at clinical assessments. And so we conclude overall that the model shouldn't be deployed without further assessment or intervention. Next slide. Okay, and just a few final points to conclude the tutorial today. So researchers have developed ways to redress bias in machine learning models. So one way that this is done is by adjusting model parameters, or also by modifying the training data. But this doesn't really do anything to address the systemic factors contributing to the bias. So for example, let's say we fix our model to reduce false positive rates in Black men or Hispanic women. Will this actually increase their access to care or treatment? Or will it help clinicians better differentiate between symptoms of depression or schizophrenia in these groups? Probably not, right? So as we've demonstrated in our case scenario, the problem is more nuanced and the solution is probably more complicated, requiring collaboration between researchers, clinicians, and public health and policy administrators. So we definitely need more research into these issues and interventions that can address them. And in fact, there's also research to suggest that if you force clinicians to carry out more consistent and structured assessments, a lot of this diagnostic bias goes away, though not all of it. So the point here is not that we shouldn't be using machine learning to automate clinical tasks. This will probably happen whether we like it or not, but that machine learning can help us better understand the potential health inequities present within a health system, many of which we might not catch because our own biases might be preventing us from seeing and thinking about the inequities. But it really underscores the potential of machine learning to identify contributing features that warrant more research and to improve current practices. So that concludes the second part of the tutorial, and thank you for listening.